My name is Olalekan, a consultant cardiologist with the Limi Hospital Group. And today, like introduced, I will be talking about atrial fibrillation, and I'm very grateful for the opportunity given this afternoon to be able to talk on behalf of the hospital on this, and also to be able to share the stage with Dr. Ojji. So this afternoon we'll be looking through approach to diagnosis and management. And we're going to go through a case presentation, look quickly through introduction and some epidemiology. Then we'll discuss the mechanism of atrial fibrillation, classification and risk factors, how we will make a diagnosis, and talk about management, and we'll conclude. The case I'm presenting is that of a 50-year-old woman who presented to us about 3 weeks ago. She was referred from a peripheral center with 3 months history of palpitation, with associated dyspnea. She had autopnea, cough, and leg swelling. She has been on clexane, carvedilol, and furosemide before we saw her. On examination, she was dyspneic at rest with bilateral pedal edema. She had some anterior neck swelling. The cardiovascular examination, the pulse was regularly irregular, and the heart rate was about 160 per minute. The blood pressure at presentation was 90/62, and the heart sound was totally chaotic, and there was a pan-systolic murmur at the apex. The JVP was also raised, and there was a tender hepatomegaly. And provisional diagnosis then was that of heart failure precipitated by atrial fibrillation, and the investigation order include ECG, full blood count, thyroid function test, echo, and I just listed the important one. The T3 was elevated. I'll show the ECG later. Then the echo showed left ventricular hypertrophy, left ventricular diastolic dysfunction. The systolic function was impaired, and the left atrium was also dilated with some degree of mitral regurgitation. And this is showing the guest ECG, and on the ECG, we can see that what we have is we don't have a discernible P wave. Then there is irregularity of the RR interval as shown by my arrow. So, and the heart rate based on the ECG was about 150 beats per minute. She was admitted, and we treated her for heart failure, and with addition of beta blocker, digoxin, and she was also placed on anticoagulants. And she was discharged home a week after having made remarkable improvements. And we've seen her once after discharge at the clinic with much lower heart rate at about 78 beats per minute. The BP has improved, and clinically, she has done well with the treatment offered. So going through the introduction, atrial fibrillation from study is the most common sustained arrhythmia seen in clinical practice. And the hallmark of atrial fibrillation is there's disorganization and irregular atrial activation, which leads to deterioration of the mechanical atrial function. And due to this disorganization of the activity of the atrium, the contribution of the atrium to the normal ventricular filling is lost, with some other associated problem. The ventricular response is also rapid, but the ventricular response varies. It could be rapid, it could be slow, sometimes it could be even regular, depending on the status of the ventricular node. So, but the typical feature we find is rapid ventricular response that is irregular, and that's why we see on the ECG the irregularity of the RR wave on ECG. And this is just depicting what I talked about. On the left, we have the normal flow of impulse generation from this sinus node through intra-atrial fiber, both atria got the response, then passed through the AV node, some delay, then through the east bundle down to the ventricle. But what we have in atrial fibrillation is you have disorganization and chaotic activation of the atrium due to enhanced automaticity and some re-entry, multiple re-entry circuits in different parts of the atrium, most commonly around the pulmonary veins in the left atrium. So what you have is irregular and uncoordinated activation, and you can see a lot of the impulse bombarding the AV node. So it depends on the property of the AV node and the refractory period of the AV node that will determine the amount of impulse that goes down through the AV node to the ventricle, and so resulting in the irregular activation of the ventricle and the irregular RR interval. So what are some of the implications of this uncoordinated atrial contraction? One, there's reduced diastolic filling due to reduction in the diastolic time due to the uncoordinated contraction, and this leads to decreased cardiac output and increased morbidity and mortality. Then I also said that there's rapid ventricular response. This can result in tachycardia mediated cardiomyopathy. As we know, the heart itself is perfused during the diastole, and because the diastolic time is shortened, so there's reduced coronary circulation of the myocardium, which can also result in possible ischemia. And due to the uncoordinated activity, we tend to have stasis of blood, which promotes clot formation. Then you can have thromboembolism in terms of stroke or other thromboembolic events. All this works together to increase morbidity and mortality in this group of patients. And like I said, a patient with atrial fibrillation, irrespective of the type, as we'll see later, the risk of stroke is increased. In patients with non-valvular atrial fibrillation, though that word non-valvular is being jettisoned in the recent updates, but we're talking about atrial fibrillation not due to mitral valve problem, the risk of stroke is increased about 5 times. While in patient that has the atrial fibrillation secondary to mitral valve problem or prosthetic valve problem, about 20 times increase in the risk of stroke in these patients, telling us that in this group of patients, apart from looking at all the clinical disturbance, we have to place a high premium in these people in preventing clot formation and by extension, preventing stroke in this patient. Then, as we will see later in the type, some group of patients can have silent atrial fibrillation where the patient is having atrial fibrillation but is not manifesting any symptom. Even in this group of patients, the risk of stroke is also increased. So appropriate use of antithrombotic therapy and control of other associated risk factors like hypertension, hyperlipidemia is very important to reduce the risk of stroke in these patients. And looking through few epidemiological data, in a study reviewing epidemiology of atrial fibrillation in sub-Saharan Africa, in this study, about 72 studies were used in this study. And the community-based average of atrial fibrillation was 4.3% and 0.7% in the age group stated respectively. And you can say, okay, based on the data as we know, the risk of atrial fibrillation increases as the age goes up. So while in young patients, maybe patients less than 20, 30, the incidence or the prevalence of atrial fibrillation is approximately 1 to 2%, while in elderly patients from the age of 60 and above, you have between 8 to 9% prevalence risk. But like we find in this study, the prevalence was higher in patients 40 years and above, while lower in 70 years. And like you know, this is a community-based study. As you know, hospital-based study will show more of elderly patients. And the prevalence range between 6.7 to 34.8% in patients with stroke, about 9.5 to almost 47% in patients with rheumatic heart disease, and between 5 to 31% in patients with dilated cardiomyopathy. And looking through the studies, the major risk factors in sub-Saharan Africa for atrial fibrillation was hypertension in about 30% of patients, followed by cardiomyopathy, 20%, and then valvular heart disease. And the commonest complication found in them is stroke, is heart failure, followed by stroke. So about 2/3 of them have heart failure, as we will see that atrial fibrillation can precipitate heart failure, and heart failure also can lead to atrial fibrillation, as we will see later, and stroke in about 10 to 50% of them. So heart failure, stroke, very common in them. And the study also showed that the appropriate use of anticoagulation is very, very poor. And looking through the management modality, rate control was the most therapeutic strategy used in about 65 to 95%. And the good thing is about 85 of them achieve good rate control. And looking through studies in Nigeria, most studies are hospital-based studies. So I just picked a few. Looking at a study from Jos University Teaching Hospital, among patients with hypertension, atrial fibrillation was the commonest arrhythmia found in them in about 6.5% of cases. Professor Omotoso and others in Ilorin also found a prevalence of 13% among patients with hypertensive heart disease. And agreeing with this sub-Saharan study, almost 71% of those patients were in heart failure. And from Enugu, about 3.5% of people that did ECG had atrial fibrillation, with more males, and more of their cases were 50 years and above. And looking globally, the prevalence is also high even in the developed country. And at least this is one of the conditions that is more common in the Caucasian than Africa. So in Europe, about 1 in 4 middle-aged adults will develop atrial fibrillation. And the European Union, they are estimating about 120,000 to 215,000 new cases every year. And by 2030, they are projecting that about 17 million people will have atrial fibrillation. So you see, we are dealing with a big problem. And going by gender, it is commoner in male compared to female. But the risk of death is similar in both gender. Being female is an additional risk factor for development of stroke in patients with atrial fibrillation. So that made them to be at greater risk and at greater risk of developing stroke. And so they should be looked at, and they should even be given more anticoagulant. Bleeding risk on anticoagulation is similar in both sexes. And when a woman has atrial fibrillation, the symptom burden is more compared to that of the male counterparts. So what is the mechanism? The mechanism of development of atrial fibrillation is very complex, but simplifying it, we can look at the mechanism that starts the process and the mechanism that sustains the process of atrial fibrillation. So we have drivers that start the own problem, and this driver is due to enhanced automaticity and trigger effects around the atrial tissue, around the pulmonary vein. And this is because the tissue around this area, their architecture is different, and they are also prone to some electrical and chemical changes that can induce enhanced automaticity and promote multiple reentry circuits. So it's the atrialized tissue around the pulmonary vein mainly that is the main driver of the atrial fibrillation. And once this happens, then changes that happen in the atrium due to atrial fibrillation and some other factor now tends to perpetuate the process of atrial fibrillation due to process of remodeling that takes place in the atrium. So external structures such as structural disease, hypertension, diabetes, and also atrial fibrillation itself induce progressive change of structural remodeling. And what happens in this structural remodeling? There's proliferation of fibroblasts, connective tissue deposition, fibrosis, infiltration of fatty tissue around the atrium, and hypertrophy of the atrium. All this working together to lead to atrial fibrillation, electrical dissociation between muscle bundles, and local conduction problem in the atrium. So all this now works to now perpetuate this process of atrial fibrillation, and that is why they said atrial fibrillation begets atrial fibrillation. And one point here is that some of this remodeling often starts even before the clinical manifestation of the atrial fibrillation itself. And some of these changes are irreversible. And that is why we need to intervene as early as possible, because the longer the patient keeps having atrial fibrillation, the more the remodeling the patient has, and the more difficult it is to be able to terminate the atrial fibrillation that the patient is having. And this just put together what I've talked about. So extra cardiac factor, hypertension, obesity, sleep apnea, hypothyroidism, inflammatory changes, activation of the renin-angiotensin system, autonomic system, all leads to remodeling, which include fibrosis, dilatation, ischemia, hypertrophy of the atrial fibrillation, resulting in local conduction problem, reduction in action potential duration, increased refractoriness, increased automaticity, and abnormal handling of calcium within the atrium. So all this now leads to atrial fibrillation, and the cycle continues if you don't terminate this process at one point or the other. So we'll quickly take a poll.
Okay, so we'll take a poll now. Let us all vote, please. Okay, just a few seconds more. Okay, we hand the poll.
Thank you very much for participating in the poll. We'll get the answer to the question as we go on in the presentation. So we are going on to discuss pattern of atrial fibrillation or classification of atrial fibrillation. Classification can be done based on timing and based on the underlying cause of the atrial fibrillation. Starting with classification based on timing, you can classify atrial fibrillation into first diagnosed atrial fibrillation. That means you are diagnosing the patient for the first time. You've never seen the patient before. And this is irrespective of the severity or symptoms, but just the first time. Then we talk about paroxysmal atrial fibrillation. This is atrial fibrillation that starts and stops on its own, usually within 24 to 48 hours, but some can last up to 7 days, not more than 7 days. So, like I said, it can start and stop on its own, self-terminate, but even atrial fibrillation that is cardioverted within 7 days is also classified as paroxysmal. Persistent atrial fibrillation, when atrial fibrillation lasts longer than 7 days, including whether it self-terminates or cardioversion was done either electrically or using medication. Then long-standing atrial fibrillation is atrial fibrillation that has lasted longer than a year. And in this group of patients, rhythm control strategy can be adopted. And permanent AF, when there is an agreement between the doctor and the patients that rhythm control strategy are no longer pursued. And here we are now going into rate control strategy. So at that point, the atrial fibrillation is now labeled permanent atrial fibrillation. So going back to the first question for our poll, the poll said the patient has been having it for 2 weeks. So for that patient, based on timing, it is a persistent atrial fibrillation because said has been having the problem for about 2 weeks. And now, based on secondary cause or underlying etiology, we cannot classify atrial fibrillation into whether it's secondary to structural disease, whether it's due to a focal problem, post-operative, and here you see atrial fibrillation with mitral stenosis or prosthetic valve, what we refer to in the past as valvular atrial fibrillation, then atrial fibrillation in athletes, and monogenic due to some inherited cardiomyopathy or channelopathies. So once you have a secondary cause that you can identify, it is preferred to classify your atrial fibrillation based on this second classification rather than using the persistent paroxysmal or the permanent classification. And risk factors, there are multiple risk factors, and about 60% of patients with atrial fibrillation, we have at least one risk factor. And if you remember, there's something that used to be called lone atrial fibrillation in younger patients without structural heart disease. That is not used so much now because if you probe, you will readily get at least one risk factors that you can ascribe the atrial fibrillation to. And the importance of identifying risk factors is if you control some of these risk factors, it is possible to prevent some cases of atrial fibrillation, especially among the risk factors that are reversible. Maybe, for example, patients with thyroid disease and some like that. And this is just table showing, listing some of the risk factors: hypertension, heart failure, thyroid dysfunction, obesity, diabetes. So we can always go through this when we get the slides. And the diagnosis is made based on patient presentation, examination, then confirmation by either a 12-lead ECG for patients that has a clinical manifestation, or the use of ambulatory reading monitoring like Holter, event recorder in patients with silent atrial fibrillation. And so this is important, especially in the elderly age group, maybe elderly patient presenting to you with stroke, which you cannot know. These people, studies have found that majority of them had silent atrial fibrillation, which was not identified before until the patient now comes down with stroke. So what are some of the clinical features? Like I said, it could be a silent atrial fibrillation in which there is no symptom. Maybe due to one reason or the other, the patient came to you and you did an Holter and you found this. Then majority of patients present with fatigue or lethargy. We talked about shortening of the diastolic time, reduction in diastolic filling, reduction in cardiac output. So many of them are just weak. Many of them can present with palpitation. We talked about this when we had the presentation on palpitation, dyspnea. Some with associated myocardial issue can have chest pain or chest tightness, and it could really be distressing, resulting in psychosocial distress. And like I said, stroke is very, very common in them. And we should not forget, some patients will now present with maybe some symptoms of associated disease condition or underlying disease condition, like the case presentation that we made. Patient presents with more features of heart failure than features of atrial fibrillation. And so other things you need to consider in the history, like I said, symptoms associated with other associated factors, we want to ask based on the timing to classify. Then you want to see the frequency. You want to ask about drugs that has been taken, then presence of other associated disease condition. Then you want to know how severe is the symptom, like we do for heart failure using the New York Heart Association. There's also European Heart Rhythm Association case similar to NYHA. Starting from patient with no symptom, that's silent atrial fibrillation, then stage 2A, 2B with normal daily activity not really affected by symptoms. By the time you get to stage 3, the patient's daily activity is affected by symptoms, and by stage 4, the patient has very severe symptoms and cannot carry out any of their daily activity. And some cardiovascular examination, the pulse is irregular, but maybe not for this class, like we said, due to some reason, maybe some blocks, associated complete heart block, you can actually have regular pulsations sometimes in patients with atrial fibrillation, but commonly what you have is irregular pulse. And the auscultation too, the heart sound is irregular. Then you can now get examination finding depending on the other associated disease condition. Like our patient that we presented, we find things in keeping with hyperthyroidism, neck swelling, and the rest like that. And ECG is very, very important. You need to identify the reading on the ECG. And ECG will also help you sometimes to show some other structural heart disease or coexisting atrial fibrillation. Atrial fibrillation can coexist with other arrhythmia, like atrial flutter, other supraventricular arrhythmia, and even sometimes some ventricular arrhythmia. So ECG will help you to look at this. And what are the typical things we see on the ECG? There's no distinct P wave because of the chaotic contraction that is happening. All you see is just fibrillation. You just see a wavy line. And in patients with some acute or severe, you may not even see anything, just see a straight line, and the R wave is irregular. But in patients with chronic atrial fibrillation, the line will be so coarse, almost looking like that of atrial flutter, sometimes even looking like a P wave. So this just to depict what I've mentioned. So what you see is more of fibrillatory waves. You cannot really discern a P wave. Then the RR interval is irregular. So there may be other features on the ECG, like we see the T wave changes and stuff like that. But for atrial fibrillation, absence of P wave, irregular RR interval. Then transthoracic echocardiography will help you to also, like I said, identify other structural disease like valvular heart disease. You can assess the atrial size, ventricular function, identify left atrial thrombus. But we should note that the sensitivity of the transthoracic echo to identify thrombus is very low. So transesophageal will be better because most of the thrombus is located in the left atrium appendage, and you can also identify pericardial disease. Then blood tests to assess thyroid function, renal function, liver function. I can actually see from the second question in the poll that most people picked liver function tests. Actually, everything on that question is actually right. Hepatic and renal function are also important, both in the diagnosis and also in the management, especially when it comes to anticoagulation of patients, because you need the two systems to function well to minimize the risk of bleeding. So actually everything on that second question is actually correct. Then you may need to do a 6-minute walk test for you to be able to assess the heart rate of the patient with exercise and to also assess the adequacy of rate control. Then exercise testing is also important to assess the rate control. You may want to do it to reproduce atrial fibrillation that is induced by exercise, then to exclude ischemia in some group of patients. So I've talked about Holter, then the importance of doing the transesophageal echo to assess left atrial thrombus. Then other advanced investigations include electrophysiological studies, where you can identify the sites where this abnormal impulse generation is coming from, and in the process you can also ablate. So it is both diagnostic and therapeutic, and chest X-ray, rule chest infection, and other conditions in the chest. So now going through the management. So going through the management, our aim in the management of patients with atrial fibrillation is one, you want to identify secondary causes and other associated causes and deal with them. You want to manage rate and reading control, especially in patients having acute atrial fibrillation, having paroxysmal, not persistent or long-standing. You want to assess the risk stroke of the patient and manage accordingly. And for patients with long-standing, permanent, you want to see what you can do about rate control, and some of them may electively need some cardioversion for symptomatic improvement. So the desired outcome from each domain of this management plan is to achieve hemodynamic stability. We want to reduce cardiovascular risk, prevent stroke, and ultimately improve life expectancy of our patients. And these are just conditions in which you need to refer your patients for specialized care. Once patients with atrial fibrillation has hemodynamic instability, you cannot control the heart rate, Some of them may end up having bradycardia, stroke. Some of them may have angina or worsening ventricular function, like in the patient that we presented. This group of patients needs to be seen by specialists. So we'll take a small break to do the second poll.
So we'll take a second poll now. Let us all endeavor to participate. So there's a poll, there's a question. Let's all participate. Okay, that's time up. Okay, so let's see how we voted. You have to share your screen again.
Thanks for participating in the poll. We'll get to answer the question as we go on. So, by the management, I will start with anticoagulation. And like I said, looking at the aim of management, you have to assess the stroke risk in this group of patients. And as you're assessing the stroke risk, because of need for anticoagulation, you also need to assess the bleeding risk along at the same time. So in assessing the risk of stroke in these patients, what is currently used now is the CHART-VASc score. Used to be the CHART score in the past, but now has been improved on. So the CHART-VASc score include C is the congestive heart failure, the H for hypertension, age, score of 2 for patients 75 years and above, diabetes mellitus, history of previous stroke or transient ischemic attack, or any thromboembolic event, take the score of 2. Any vascular disease, maybe peripheral arterial disease or aortic plaque. This brings to 4 the importance of doing the Doppler of the carotid to assess for aortic plaque. Then age again, between 65 to 74, and sex category. And that's why I said, being a female increased the risk of stroke in patients with atrial fibrillation. And looking at the last poll question, a female, Mrs. whatever, the age was 75, that is 2. She is on antihypertensive, so definitely she has hypertension, that is 3. So the least score she could have is 3. So 3 is the right answer for that first question in that poll. Then I think she's also on metformin. So the score is at least 4. Then even if you put, the score is at least 4 for that patient. So 4 is the right answer in that poll. Is it 4? It's 5 because she's 75. So for age is 2, a score of 2. So, but the least score she could have based on our answer is 4. So like I said, we also need to assess the bleeding risk. And bleeding risk, you have to look at modifiable bleeding risk factors and non-modifiable, and the one that are potentially modifiable. So hypertension, uncontrolled hypertension is a risk factor for bleeding. Patients with INR not in therapeutic range between 2 and 3. Patients on other drugs, not like non-steroidal, on antiplatelets, then excess alcohol intake increases the risk of bleeding if you start them on anticoagulants. So you need to look for this and manage appropriately. The one that are potentially modifiable, renal function, liver function, platelet function, and that's why I said in the first question, the liver function test is also important. May not be directly in the diagnosis, but in the management, it's also important. Then the non-modifiable bleeding risk factor is as stated on the slide. So after assessing the stroke risk factor using the transfer score, so what do you do? For patients with transfer score of 0, you don't need to give anything because the risk of stroke in them is very, very low. For patients with stroke risk factor score of 1 for male or for 2 for female, in the past it used to be said that you should give them aspirin. But the latest update is that you should consider the use of oral anticoagulants in this group of patients because it's been found that it is better. The stroke risk prevention is higher than giving them platelets, and the side effect of bleeding is similar whether they use aspirin or they use oral anticoagulants. So it is better. And you have to consider some individual characteristics in that patient for you to make your determination. But now, use of antiplatelet monotherapy for prevention of stroke is no longer advised in patients with atrial fibrillation. And for those with score of 2 and above, then you can use vitamin K antagonist warfarin or NOACs. But NOACs is preferred for the patients that you can give non-vitamin K antagonist oral anticoagulant. It is actually preferred to them because 1, the risk of prevention, they are non-inferior when compared with warfarin. Then the risk of having fatal bleeding, maybe cerebral bleeding, is even lesser compared to warfarin in them. The only thing that is a bit higher in patients on NOACs compared to warfarin is the risk of gastrointestinal bleed, and you can use omeprazole and other things like that to stop that. But patient that has atrial fibrillation secondary to moderate to severe mitral stenosis mechanical heart valves, they should be on warfarin. It's a class 3 recommendation that you don't give them oral anticoagulant. And this is just saying the same thing I've mentioned. But the take home is in the class 3, the harmful. Don't combine oral anticoagulants and antiplatelets under the guise of you are trying to prevent stroke, except if there are clear indications for it. We'll mention it shortly. Then, if there is no risk factor, transfer score is 0, you don't need to give anticoagulants or antiplatelets. Then, like I said, the use of antiplatelet monotherapy is no longer recommended, and don't give NOACs in patients with valvular atrial fibrillation. So this is just showing studies on the NOACs. Then, for those people that they've developed the stroke, what are you going to do? Don't start anticoagulants or heparin immediately after the stroke. You need to wait. This is now the time where you can give them your aspirin while waiting. So here, you can give aspirin while waiting. Then if patient has TIA or small stroke, maybe like after a day or 2, you can start your oral anticoagulant. But for patients with major stroke, you need to wait longer before you start them. And this chart is just showing that TIA minor stroke, maybe a day or 2 after. For my stroke, you can wait till 3 days. But for patients with moderate, severe stroke, you may need to wait a week or even 2 weeks to assess them before you commence them on anticoagulant. Like I said, while you are waiting, these are the type of patient now you can give your antiplatelets. For those with hemorrhagic stroke, it is advised that you wait for about a month or 2 before you recommence your oral anticoagulants. And for patient now on anticoagulant that is bleeding, so you need to manage that too. So if the bleeding is minimal, so you can identify the sites and address it accordingly. Do your PCV, check the kidney function, all those modifiable risk factors. If the blood pressure is not controlled, do that. And for those with moderate to severe bleeding, they may need to be transfused with blood. And depending on what you are using, if you are using warfarin, you may need to give them vitamin K. And for severe bleeding, you will definitely need to stop, transfuse, do appropriate antidote for the ones you are using. And I think we've had a discussion on anticoagulants somewhere about some weeks ago, so we can look through that to see specific antidote for specific agents that you're using. Then I talked about combining anticoagulants and antiplatelets. I said only in specific conditions, and that is when patient also has acute coronary syndrome and going for PCI. So in those groups, if you assess the bleeding risk and the bleeding risk is low, you will use the 3 of them. You know, post PCI, we give them dual antiplatelet, clopidogrel and aspirin. So you can use those 2 plus your anticoagulant for about first 6 months. Then between 6 months to a year, you remove one of aspirin and clopidogrel and still continue with your anticoagulant. Then subsequently thereafter, stop your antiplatelet and continue your anticoagulant. But for those with high bleeding risk, the triple therapy is done for only 1 month. After 1 month, stop one of the antiplatelets, continue with drug therapy for the next 11 months, then thereafter, leave them on anticoagulants. Then for those with stable coronary artery disease that are going for elective PCI, in them, whether the bleeding risk is low or high, just leave them triple regimen for only 1 month. Then subsequently, drug therapy. Then after like a year, you can now continue your oral anticoagulants alone. So What was the second question on the previous poll, so that we can answer it before we go? I can't seem to remember. Okay, she had a stroke. So what will your recommendation be? Like we have said, there's no place for antiplatelet monotherapy, so aspirin is there. Giving them dual antiplatelets, you will only increase the risk of bleeding. There's nothing you're going to gain. Like I said, it's now between NOACs and warfarin, and like we said, for those that can use NOACs, is actually preferred above warfarin. So in this question, we'll pick non-vitamin K antagonists or anticoagulant as our answer. So let's take our final poll before we continue. Okay, sorry. So let's continue. So what we'll look at rate control, rhythm control, and cardioversion in the management of patients with atrial fibrillation. So in patients that is presenting acutely, patient having paroxysmal atrial fibrillation, rate control improves symptoms and also improve their hemodynamic status. So what do you do? If the ventricular function is good, use your beta blocker or your calcium channel blocker, the non-dihydropyridine, diltiazem or verapamil. And what you are targeting is to have a lenient heart rate reduction once you have less than 110. But some studies actually are pushing for about around 80 if the patient has high burden of symptoms. Then if this is not giving you your adequate results, you can add digoxin. Then for those with left ventricular systolic dysfunction, you know, due to the negative inotropic effect of those calcium channel blocker, you cannot use that. So you start with them with beta blocker, and you can later do an add-on of digoxin. And in both, you avoid bradycardia in them. And the need for anticoagulation should be assessed and should be dealt with. Then for those with long-term, permanent, long-standing, is still going through the same paths. Good systolic function, your diltiazem, your beta blocker, and your digoxin. But on the other side, beta blocker and digoxin. Then we should also note that some anti-arrhythmic drugs, though they are more for rhythm control, can also be used for rate control. For example, imidazole, especially in patients with compromised left ventricular systolic function. Then this race 2 trial looking at doing a lenient rate control or a strict control, whether just leave them at less than 110 or going down as low as 80. And it was found that none is superior to each other. So symptoms, adverse effects, quality of life are similar in both. So you don't need to break your neck to achieve less than 80. So for rate control, little symptoms, lenient rate control. But for those with high body symptoms, you can try to get a more stricter control of your heart rate. Then, for those with hemodynamic instability, now you need to address that. And for those group of patients, you need to try to restore them back to sinus reading as soon as possible to improve their hemodynamic state. And this is where cardioversion comes in, which can be done either electrically or using anti-arrhythmic drugs. Electrical cardioversion is much quicker, much more effective, and you also avoid the side effect of the anti-arrhythmic drugs. But for patients that are conscious, you need to sedate them. You may need the service of also of an anesthetist. And so it's good for improvement in symptoms of the patients. And for patients that are not in acute state, patients can also prefer to do cardioversion. So it is also allowed in some group of them. And using some antiarrhythmia before the cardioversion actually also improve the success rates of electrical cardioversion. And so, just going through this table, recent onset atrial fibrillation with hemodynamic stability, you need to cardiovert the patient. No hemodynamic instability, but patients want to do it. You can also do electrical cardioversion, or now you can now go through pharmacological cardioversion using your anti-arrhythmic drugs. And it is listed for patients with no underlying structural heart problem, flecainide, ibutylide, propafenone can be used. But those with structural heart disease, it's advisable that you use amiodarone, which is readily available. Then we can do what we call pill-in-pocket cardioversion using flecainide and propafenone for patients with no structural heart disease. The patient keeps the drugs, and when they have their fibrillation, they can quickly use the drug to terminate the episode. So, and now, stroke prevention in patients with atrial fibrillation, in patient that is going for cardioversion. For anybody having atrial fibrillation that is more than 48 hours, or you can ascertain the duration, you need to anticoagulate the patient for at least 3 weeks before cardioversion, then at least 4 weeks after the cardioversion. So you need, so that you don't dislodge a stroke from the left atrial appendage after cardioversion. And for those with less than 48 hours, you may need to quickly do a transesophageal echo to rule out thrombus in the left atrium or the left atrium appendage. And once you can do that, you can do your cardioversion, but it is still advised that in that group of patients, still start them on anticoagulation. And for those less than 48 hours, you can do your cardioversion without anticoagulation, but it is advised, irrespective of duration, start your anticoagulation and continue for at least 4 weeks after the cardioversion. So for long-term bleeding control, also follow the same. You consider underlying structural disease or no structural disease. Once there is no structural disease, you can go flecainide, propafenone, and all that. But once there is any form of structural disease in this environment, just think of amiodarone. Then other non-arrhythmic drugs that also help improve rhythm control include the use of ACE inhibitor or ARB and beta blocker, especially in patients with depressed left ventricular ejection fraction. So it is good you give this group of patients. Then thinking, which one should I do? Is it rate control or rhythm control? Several studies have been done, but the two largest studies that I want to quote is the AFAM study and the rate studies that looked at the two, and they really found that one, they are not that superior to each other, but they even found that the rate control result in fewer hospitalization. But we should note that in FR, most of the patients after restoring sinus rhythm, the anticoagulant was stopped. And that they explained the reason why the group that had rhythm control now have more hospitalization. But the summary of the two major studies is that none is superior to each other. So you need to consider what you're dealing with, especially in patients that you are now entering into a permanent atrial fibrillation. You can see there is no serious benefit the patient is going to derive from rhythm control. So you just go for your rates control. And maybe in an environment where even most of the anti-arrhythmic drugs are not available, or we are afraid of the side effects, we can easily do rate control. And we can see from sub-Saharan studies that over 80% of patients achieved rate control with the use of rate control medications. And surgical components of achieving rhythm control, like I said, during electrophysiological study, you can do catheter ablation, so through which you can do pulmonary vein isolation and ablation. you can ablate the AV node and place the patient on a permanent pacemaker. Then left atrial appendage closure surgery could be done. Then, and MACE procedure used to be done. What is done in MACE procedure is scars are created in the atrium to serve as block to propagation of some of these chaotic atrial depolarization, so that you reduce the number of electrical activity that is getting to the atrioventricular node. So this has been found that you can also do occlusion of the left atrium appendage, like I said. So this has been found that some patients improve with this, but some patients can even do what we call an hybrid management, where you do the medical management, you also combine that with either catheter ablation or surgical ablation or surgical occlusion. And doing hybrid management tends to improve the overall income. And this table is just listing the complication from catheter ablation procedure. So when you do surgery, if the patient is going for any open heart surgery and rhythm control therapy is desirable to achieve symptomatic improvements, and the patient also agreed to do a surgery, so you go ahead and do the surgery. But patient does not want, and you continue with what you are doing. And like I said, I talked about hybrid therapy, especially if one aspect is failing. Maybe you are failing in terms of anti-arrhythmic drugs. You can actually combine them, do the surgical management and also do medical. So concluding, we should also not forget that pregnant women can also have atrial fibrillation. So for rate control, you can use your beta blocker. You can use your digoxin, is in class C, so you can use them, except atenolol in beta blocker. Then they also can be anticoagulated, and it is advised that in the first trimester and the last month of pregnancy, you avoid the use of oral anticoagulants. And you can also cardiovert them, but where you are going to do cardioversion, you must make sure that there is provision for emergency CS and for management of fetal distress if you have that. But class 3 recommendation, which is harmful, the use of NOACs should be avoided in pregnancy. So you are limited to warfarin or your low molecular weight heparin. So in summary, I'm just going to give the points listed in the 2016 Europeans. So screen patients, especially adults, document your finding by ECG before you start treatment and evaluate other associated factors. Carry your patient along in the management and what you're going to do, whether rhythm control, whether rate control. You should treat underlying factors. You use oral anticoagulation based on your Chart-VAS score. Don't use aspirin or don't use antiplatelet alone. Then we talked about achieving good heart rate control. And like I said, do not use antiplatelets and do not discontinue your anticoagulant prematurely. Some of these patients might actually need to be on anticoagulant for the rest of their life. Do not use rhythm control therapy in asymptomatic patients or in patients with permanent atrial fibrillation. Do rate control in this patient. Do not perform cardioversion or catheter ablation without anticoagulation, or except you have ruled out presence of thrombus in the left atrium or left atrial appendage by transesophageal echocardiogram. Thank you for listening. These are some of my references. Thank you very much.
Thank you, Dr. Olalekan, for that wonderful presentation. That was a great one. I think we'll take some of the questions now. So I'll just go through some of the questions in the chat box now. Before I read the questions, I want to thank all the attendees for being a part of this presentation. Thank you so much for listening and being there all through. Dr. John Wimago asks that you mentioned that giving aspirin in the event of a stroke during the initial 2 weeks. Does this also apply for hemorrhagic stroke? Because he says that in practice, he knows that we need to get a brain CT to rule out hemorrhagic stroke before aspirin is given. So again, he's saying that in a patient with atrial fibrillation with hemorrhagic stroke, do we give aspirin during that waiting period before the anticoagulants are started? So I think maybe you answer that first before I go to the other one.
Okay, thank you, Dr. John. When I was talking about the aspirin issue, I was talking about ischemic stroke. So, said a patient with ischemic stroke, while you are waiting, you may put them on aspirin. So this slide is talking about patients with ischemic stroke. Then the next slide is talking about hemorrhagic stroke, where I said you may need to wait about 4 to 8 weeks before you resume your anticoagulant. In patients with hemorrhagic stroke, you will not give them aspirin. So the use of aspirin is in patients with ischemic stroke confirmed by CT or other neuroimaging. Thank you very much.
Thank you for that response. And I would just want to add that what he added, that's about avoiding aspirin, avoiding the oral or other anticoagulants in the first week after ischemic stroke is actually to minimize the risk of hemorrhagic transformation. Okay, so many guidelines recommend that we are safer with aspirin in the first 2 weeks after an ischemic stroke before we fully anticoagulate the patients the way we'll do for a patient with atrial fibrillation. So it's suggested that that's best delayed until after 2 weeks. Thank you so much, Dr. Olalekan, for that response. The other questions that are here in the chat box is that, will it be okay to place all hypertensive patients on antithrombotic agents, that is on antiplatelets? Sorry, you said they meant anticoagulants. So will it be okay to put all hypertensive patients on anticoagulants? What do you think about that? That's the first question. I will also read the next 2 questions as well. How does liver function test help in the diagnosis of atrial fibrillation? I think that was misconstrued, but that's the question that was typed here. And then the last question says that, what will be the best regimen for a stroke patient with atrial fibrillation on aspirin and warfarin who develops hematuria after 2 weeks? Wow. Okay, so that's the third question.
Thank you.
Should you respond to that now, sir?
Okay, thank you very much for the question. So the question about placing all hypertensive patients on anticoagulants. What we're discussing here is in the context of atrial fibrillation. So it is not a caveat that all hypertensive patients should be placed on anticoagulants or antiplatelets. So you need to assess your patients. So we're talking about atrial fibrillation in context of hypertension. So presence of hypertension and other factors increase their risk of developing stroke. So it is in that light that you now decide what you want to give, either your vitamin K antagonist or your non-vitamin K antagonist oral anticoagulant. So it is not all hypertension patients that once you see an hypertensive patient as part of the treatment, you will give them anticoagulants. No, sir. Then, about the question on liver function test in the diagnosis of atrial fibrillation, I think I tried to make the clarification that in the diagnosis of atrial fibrillation, liver function test may not actually come to play. But when you are assessing their stroke risk and bleeding from the use of anticoagulants, any patient that has abnormal liver function, maybe patient has liver cirrhosis, has elevated bilirubin level, has elevated ALT, AST, more than 3, the upper limit of normal, they are at increased risk of bleeding. So you need to address that while you are giving them anticoagulants so that you reduce their risk of bleeding. So the LFT is not directly involved like in the diagnosis of atrial fibrillation. So thank you for the question. Then Dr. George asked about what would be the best regimen for stroke patients, aspirin and warfarin who develop hematuria. This is one of the reasons, one, that we said it is not recommended that you combine antiplatelets and oral anticoagulants for patients under the guise that you are trying to prevent stroke. That's number one. Number two, since we know that most of the patients that we have atrial fibrillation are elderly, you should also assess, because when I was talking about bleeding risk one, I said you assess, you make your that you try and identify the reason or the source of the bleeding. Is it gastrointestinal? Does this patient has a BPH, prostate CA, which is also common among that age group? So you need to look for the cause. But while doing that, you will first of all have to stop your antiplatelets and see whether that is the cause, and you assess the risk. And like I said, if the bleeding is severe, you may need to stop your warfarin, check your PT-INR. If your INR is beyond range, then you need to stop and wait for the INR to come down to less than 2, and assess other cause of the bleeding, address that before you think of starting your anticoagulant. And like we said, using your vitamin K antagonist alone is enough to prevent stroke in this type of patient, except if there is other indication for the use of antiplatelets in them. Thank you very much.
Thank you so much for the answer, Dr. Olalekan. I think I'll answer the next question. And the next question asks that, what will be the best regimen for a stroke patient with atrial fibrillation who is on, who is on aspirin and warfarin, who develops hematuria after 2 weeks? I think Dr. Olalekan has answered that. So the next question is, does dual antiplatelet therapy have a place in atrial fibrillation? And again, based on the correct guideline that Dr. Olalekan discussed, the antiplatelets really do not have a role there. In the past, people with a charged VAS score of 1 used to be given antiplatelets, okay, but it has been found, as discussed, that the benefit of this is not really there, and the risk of bleeding is almost at par to when we use the anticoagulants, which will have given a better benefit. So people with a charged VAS score of 1 in males, 2 in females, should be considered for anticoagulation, whether they need it or not, whether they will benefit more from it or not. Okay, but some people still give antiplatelets when that score is 1, but the truth is that that's not the recommendation. Okay, so someone asked again that in the case of bleeding post anticoagulation, what are the antidotes to give? Okay, what are the antidotes to give? And the antidotes to give in the case of anticoagulation, number one, Dr. Olalekan mentioned earlier that in the previous presentation, we've discussed that for warfarin, vitamin K is the most commonly used antidotes, okay, in various forms. I think it's well described in Oxford Handbook of Medicine. So oral, there's a role for oral vitamin K, there's a role for IV, and of course, there's a role for, what do you call this thing? The plasma product, the name has stopped for me now, okay? For heparin, we use protamine sulfate, okay? And then for dabigatran, which is one of the direct acting agents, a monoclonal antibody, which is extremely expensive and extremely unavailable, can also be used. I think it's idarucizumab, okay? So all of them have different agents like that, and it's good to be familiar with the antidotes for the agents that we are using. So the last question here asks that, what is the cost effectiveness of the newer anticoagulants to the older generations in terms of efficacy, risk of bleeding, etc.? That's a very wonderful question. That's a great question, okay? And I will start by reminding us that, for example, in the UK, many NHS patients are actually seen on warfarin. They are just trying to do a lot of conversion or transitioning people to warfarin. And it depends on the generally what we say here is that when you compare the cost of the medication, if you add the cost of testing to warfarin, that's cost of assessing the person's INR every several days, usually we'll realize that the cost easily gets up to being comparable to the cost of the newer oral anticoagulant agents. So that's one. And then by the time we have the inconvenience of the food restrictions, the unpredictable INRs, and other things, um, it's comparable. The only situation in which we don't really have enough data to compare in terms of particularly efficacy is for valvular related atrial fibrillation. So we can't really say they are comparable in that situation. And for now, warfarin is still the recommended agent for valvular related atrial fibrillation. In terms of risk of bleeding, we actually think the NOACs are safer than the traditional warfarin in terms of risk of bleeding. But we should always put in mind that if we run into trouble, the antidote for warfarin, which is vitamin K, FFP, is far more readily available than the antidote for the newer oral agents. I hope that answers the question. Dr. Olalekan, please do you have any other addendum to that, sir?
I think you've actually answered the question, because looking at the studies, like I said, they are not inferior, the NOACs are not inferior to warfarin. Then, like you said, the problem of monitoring, ability to achieve therapeutic range, all those ones. So at the end of the day, you find out that the cost is really not as expensive as you find, because the patient on vitamin K antagonist will buy the drugs, pay for PTINR frequently, avoid this food, avoid these medications, but just take your rivaroxaban, dabigatran, apixaban, and you are good to go. So by the time you weigh it, then, like I said, the less you have less of bleeding in critical organ compared to warfarin when you use NOAC. So I think the effectiveness overshadows the issue of cost in this group of patients. And by the time you talk to your patients well, you educate them well, we find out that many of them are now agreeing to the use of NOACs for their management. Thank you very much.
Thank you very much, Dr. Olalekan. And right now we'll invite Dr. Ojji, consultant cardiologist, to give us a short presentation directly related to this topic that we're taking now. Thank you very much, Dr. Ojji, sir.
Thank you very much, Dr. Awofisoye. And thank you, Dr. Olalekan, for the beautiful presentation. I think you've just taken everything. So I will just share my screen now. And I want to, sorry. I want to quickly share my screen. Just trying to see. Interesting. Just a minute. Let's share that. It's not it. Sorry. I know I'm finding it difficult to locate this. Sorry, I don't know. Just a minute, please. Just give me some time to save it and see. I don't know why. Oh. Okay, let me see. Sorry about the delay. Thank you very much for your patience. So good afternoon, everybody. And I thoroughly enjoyed Dr. Olalekan's presentation and the questions. So he has made my work very, very easy. What I would really talk about this afternoon is looking at the role of NOACs, what people call the newer oral anticoagulants. Whether they are new now is another story. Some people used to call them novel. At a point they said it's no longer novel because it's lasted in the market for some time. So maybe terminology newer compared to the more traditional ones is a better term. And we know that atrial fibrillation, one of the most feared complication, of course, is stroke. Dr. Olalekan has referred to this before, that AF is an arrhythmia and is responsible for 1/3 of all hospitalization for cardiac rhythms, especially in Europe and US. And you can see the burden there in Europe. About 4.5 million people are said to be living with the burden of atrial fibrillation. In Europe, and in the US, it's even greater, about 5.1. And also in the US, it's said that about 2.5% of the US population are affected by atrial fibrillation. And one important thing about AF is the fact that it's also a function of age, that as patients get older, there is greater risk, of developing atrial fibrillation. I will quickly jump this for our time because Dr. Olalekan has mentioned this before. Talking about AF pattern is very, very important to know the pattern of AF. And he has referred to this before, the traditional absent P wave and varying arrow interval. And this shows that AF is very common worldwide and is anticipated to increase. Why is it anticipated to increase? Because the world population is going to get older. And apart from that, cardiovascular disease from hypertension to diabetes is going to be on the increase astronomically. And talking about age, he said that when patients are 40 years of age and above, the risk of developing an AF, you can see, is about 25%, being higher in men compared to women. And that is even irrespective of whether the patient has congestive heart failure or myocardial infarction. In our environment, Dr. Olalekan referred to this earlier, heart failure fuels atrial fibrillation. You can see this study by Familoni that about 21% of the 82 patients he studied had atrial fibrillation. And this was also by Karaye. You can see about 19.1% of the 113 patients he studied had atrial fibrillation. We looked at about 2,400 of our patients coming to the University of Abuja Teaching Hospital. These are not heart failure patients, but these are hypertensive, presenting to us for the first time. And you can see that about 3.5% of them had atrial fibrillation when they came, being higher in men compared to women. I said this earlier, that atrial fibrillation increases with age. And you can see being higher in men compared to women. Now, the other issue we must always remember is diabetes. It also fuels atrial fibrillation. And when a patient with diabetes has atrial fibrillation, the cardiovascular risk increases. As you can see, the relative risk of about 1.7. And this tells us again, talking about the importance of diabetes. You can see patients with diabetes with atrial fibrillation, they have a higher risk of all-cause death, cardiovascular death, heart failure, and stroke compared to those without atrial fibrillation. So if there is anything you want to treat optimally in diabetic patients, one of them is atrial fibrillation. The burden of atrial fibrillation was shown also in this RELY AF registry. This was a registry that ran, I think, about 10 years now in 46 countries. And Nigeria was involved about 6 centers. My center was involved, UCH, Ibadan. I know Kano was involved, and one other 2 centers. And you can see that in Africa, the burden, patients with atrial fibrillation, about 14% of them were diabetic patients. So it shows that it's quite difficult for us to separate AF in a way from diabetes. So if there is one arrhythmia that we have to check for in patients with diabetes is atrial fibrillation. And like we've heard and we know, atrial fibrillation increases risk for stroke, for heart failure, and mortality. And in terms of heart failure, it seems to be bidirectional. Remember that atrial fibrillation can cause heart failure, and also heart failure predisposes to atrial fibrillation. Stroke is the leading complication of AF. It cannot be overemphasized. And without prevention, approximately 1 in 20 patients will have a stroke each year if you don't do anything. And this is from Nigeria. You can see here a study, a long time ago study about some years now, 2005, but it clearly shows that atrial fibrillation is one of the risk factors that we are going to be looking at for in patients with stroke. Stroke, like we said earlier, stroke is a serious complication for AF. It's associated with a heavy burden of morbidity and mortality. And it's also noted that atrial fibrillation stroke is usually more severe than stroke due to other causes. And the other thing you must realize in atrial fibrillation stroke is that reoccurrence is most likely than patients that don't have atrial fibrillation. And mortality rates for patients with atrial fibrillation is double that in people that have normal rhythm. And which type of stroke do they normally present to? For the question addressed that in most time we are dealing with ischemic stroke, but don't forget, like Dr. That was in one of the responses, you can also have hemorrhagic conversion. Of course, the pathophysiology of the stroke is quite obvious because of clot formation in the left atrium, on the left atrial appendage, and that is transported to the cerebral vessels. So it is said that most strokes associated with AF are ischemic, as we have seen, that up to 92% of them, you can see from this study, is ischemic compared to just 8% hemorrhagic. And I said this earlier, that ischemic stroke is more likely to reoccur. Why is it going to likely to reoccur? Because the etiological factor, the atrial fibrillation, is already there. And you can see this, that if people have atrial fibrillation, the likelihood of having a repeat stroke is higher compared to people that don't have atrial fibrillation. The other issue we must always remember when we are dealing with atrial fibrillation is to look at the renal function of these patients. Renal impairment, is said to increase the risk of stroke and bleeding in patients with atrial fibrillation. You can see from this study, when you compare patients without renal disease or chronic kidney insufficiency with those that have, you can see that the risk of either a stroke or thromboembolism or bleeding is far less in those without renal disease compared to those with renal disease. So for these patients with atrial fibrillation, one thing you must always bear in mind is to have their renal status well assessed. One, because of the reasons of bleeding, just like you do also for liver function tests. And the other reason is because remember that the driving factor for atrial fibrillation in an environment is hypertensive heart disease. And the same hypertensive heart disease is also a driving factor for chronic kidney insufficiency. Now, there were a lot of debate earlier on, but I think this is settled now in cardiovascular world. There's limited efficacy of aspirin in reducing the risk of stroke. Before, people were pointing that aspirin can do a lot, But from this meta-analysis from different studies, you can see that there is no difference between aspirin and placebo. It was only one study, the UKTIA study, that showed that where aspirin can have a benefit in compared to placebo. Otherwise, aspirin does not really have a place now in management of atrial fibrillation. When warfarin was compared to aspirin, which is one of the studies actually that nailed that out, we found that warfarin was far, far better, than aspirin in preventing stroke in atrial fibrillation patients. What of dual antiplatelet therapy? This was one of the questions that they were asked. It's also been found that compared to the VKAs or the traditional anticoagulants, the dual antiplatelets are not better in terms of reducing the risk of stroke. And they also have a higher tendency for bleeding, because at this time you are using two antiplatelet agents, clopidogrel and aspirin. So when they compared both, they found out that oral anticoagulants were far better and even had less bleeding compared to dual antiplatelets. So in modern day management of atrial fibrillation, especially with focus to prevent cerebrovascular accident, there is hardly any place for dual antiplatelet agents. So is there a place for the traditional anticoagulants, especially the warfarin? Yes, there is a place, but it has a lot of limitations, I can see. Remember that they have a narrow therapeutic window, as we are taught in medical school. When it comes to their pharmacokinetics, is very, very unpredictable. Wide variety of drug and drug-food interaction is another problem. Then there is a need for regular anticoagulation monitoring and dose adjustment in them. Then the other issue also is slow onset and offset of action. And I bet you, I don't know if you had that experience before, but I've had it, whereby you collect a patient's sample for INR and you send it to 2-3 labs, and they are giving you different results, and that has been an issue. Monitoring INR in them could be quite cumbersome and could be quite tricky. Also, the other issue about the traditional antithrombotic therapy has to do with bleeding into the brain. Don't think that aspirin is not an anticoagulant, it's antiplatelet, it's innocuous. It also increases the risk of bleed, as you can see, by 40%, while warfarin will double the risk of intracerebral hemorrhage. The other issue you must always remember also when we talk about the VKAs is the fact that they exacerbate renal decline. So you will now be having two factors, most likely your traditional hypertension and also the medication you are using if that patient has AF, in causing a decline. And this has been found in studies whereby warfarin, compared to placebo, has resulted in decline in renal function. And that has been attributed to intimal calcification. The matrix G protein is the main inhibitor of vascular calcification, so it inhibits vascular calcification, especially renal calcification in the body. And vitamin K is required for full activity of matrix G protein. So when you block vitamin A, when you use an antagonist, then calcification will have a freeway. And that is what happens. So with time, it's been found out from studies that patients that are on VKAs will ultimately develop calcification of the vessels, especially renal calcification. Now, VKAs also have been associated with acceleration in acute kidney injury and chronic kidney disease. And this also has to do with the pathophysiology of what I explained earlier. And on the contrary, the NOACs that have been found that they've been found to reduce proliferation of the small vessels, oxidative stress, and even remodeling. So they might have some protective effect on the vessels compared to warfarin. And if you look at this is the Rocket study. Rocket study, they compared rivaroxaban and warfarin in non-valvular atrial fibrillation. And you can see there in terms of renal function, the renal function was better in the rivaroxaban group compared to the warfarin group. And this also shows, that this is Aristotle study, and that is the Rocket study. You can see the advantage that rivaroxaban has when it comes to renal protection compared to warfarin. Even when you compare that apixaban and warfarin, you can see that apixaban didn't have too much advantage for renal protection. So what is our goal if we want to prevent to treat atrial fibrillation patient? Our main goal, of course, want to prevent ischemic stroke, and in addition also want to minimize hemorrhagic stroke as much as possible. So what is now the desirable qualities of a new anticoagulant that we'll be looking in these years of medicine, these modern years of medicine? At least it should be as effective as current agents. So if it's effective at the VKAs, at least as safe as current agents, then there should be oral administration. It's very, because these are lifelong thing most times, medication, then sustaining injection or injectables can be quite difficult. So you might want to, it is preferably that oral administration. Now, fixed dosing is very important. You want a medication that you can predict. The question came about bleeding. I don't know about my experience, my little experience with NOACs. I've hardly had any patient actually bleed to NOACs. And I've also read some articles whereby bleeding can be stopped with just giving the patient plasma, or little transfusion can do that. No need for routine anticoagulation monitoring. And this is a big issue about the VKAs, which is why many people today will run away from it, because monitoring warfarin is very, very difficult. Eye and arrow. Getting them in the lab, getting them on time, getting accurate result can be. Then again, interaction with food. You want to tell the patient to take it last thing at night. Sometimes they might forget. They might forget to eat and take it. And then so the erratic metabolism, then rapid onset and offset of action also is a big issue. It takes a long time to peak and even to also nullify the effect. So when you talk about the new oral anticoagulants, we have those that like direct factor XA inhibitors. So we're talking about rivaroxaban, apixaban, and also direct thrombin inhibitors like dabigatran. Now, the Rocket AF study actually provides some insight, because I've told you before, there is no way you can delineate the issue of chronic kidney disease or renal function in patients with high-risk cardiovascular disease. We know, remember that CKD on its own is a cardiovascular disease, and they tend to go hand in hand. So in this type of patients, like I said earlier, assessing the renal function for them is very, very important. And the Rocket AF provides robust evidence for rivaroxaban reduced dose in CKD patients that is effective, in preventing stroke in them, reducing just a dose of about 15, milligrams per day. You can see in 100% of the patient, and it's quite effective.
Please, if you kindly round up, sir, we'll appreciate, sir. Okay. We are getting out of time. Thank you very much, sir.
All right. No problems. I will just run through this. I think we should be almost done. And then we've mentioned this before in terms of bleeding. The Rocket AF also shows that. So consistent efficacy and safety. So like renal impairment is something we must not forget. And renal clearance for rivaroxaban is very, very, very good. And you can see also for the NOACs in terms of renal function, you can see rivaroxaban maintaining a very good renal function. So I will just run through because of the time. You can see the reduction for patients, look at 15, even patient with creatinine clearance of 15 mils per minute who tolerate the 15 milligrams of rivaroxaban. And why is this so? Because of the mechanism of metabolism, because only 1/3 of rivaroxaban is actually excreted, from the kidneys. Now, it has also been found in the rocket AF that the diabetic subgroup benefited immensely also from NOAC, especially rivaroxaban. So in diabetic patients with atrial fibrillation, of course, NOACs, and we found from study that rivaroxaban was very efficacious, as you can see. So I will try and round off, and this is real world situation. Of course, this is not randomized controlled trial. So in terms of preventing, in terms of ischemic stroke, hemorrhagic stroke, and if you can see how favor good profile there. So to conclude, atrial fibrillation is one of the commonest forms of arrhythmias and a major cause of stroke all over the world. Both diabetes mellitus and CKD increase the burden of atrial fibrillation. We must always bear that in mind. The NOACs are far-reaching advantage over the VKAs as anticoagulants in atrial fibrillation. And the NOACs, especially the rivaroxaban, is quite safe and useful in the setting of CKD and diabetes. Thank you very much.
Thank you very much, sir, for such a fantastic presentation. My name is Dr. Iseko. That's a fantastic presentation. We're running out of time, so we'll just take maybe one or two questions. While the questions are being prepared, the representative from Bayer would like to have a few minutes to talk, so give him a couple of minutes to talk. Meanwhile, I want to remind you that this webinar holds, now it's holding once every month, or once every 3 weeks, openly to the public, in which case we do a lot of cardiovascular education. CardioCare is a hospital in Abuja. It's an advanced hospital in internal medicine and cardiology, diabetology, neurology, and on the like. We also host a cath lab and an ultramodern facility here in Abuja. We're happy to host this webinar. Our next webinar will be on heart failure. That will be coming up in September, and we took quite an exciting time. We hope that you all be there to enjoy that as well. Over to Bayer shortly, who will be starting their presentation. You have about 4 minutes. Let's try and round it up. And CardioCare will now make the final statements. We'll also give information about how to get your. So just hold on. Okay, over to you, Ajibola. You have 4 minutes, please.
Please let me know if you see my screen.
Yes, your screen is clear. Go ahead.
Okay, so first of all, I'd like to specially thank the management of CardioCare and of course, Dr. Olalekan and Dr. Ojji for the excellent presentation. And in the next 4 to 5 minutes, I'll be sharing with us on why we should consider Xarelto as the ideal anticoagulant for stroke prevention in non-valvular atrial fibrillation patients. Like we already know, according to the Freemium study, thankfully Dr. Ojji and Dr. Olalekan have stressed about this, that patients with atrial fibrillation are 5 times more likely to have an ischemic stroke. Of course, there are different classes of anticoagulants currently available, but then when we consider, an ideal anticoagulant, just like Dr. Ojji has mentioned, we're considering an anticoagulant that is convenient to use. You would agree with me that the oral route of administration is the most convenient. We're considering an anticoagulant that has a wide therapeutic window. And of course, an anticoagulant doesn't have a lot of food-drug interaction. We're looking for an anticoagulant that would let our patients continue with their leafy vegetables, the eforiro and the afang. Traditional anticoagulants available actually have a lot of drawbacks. For instance, there's a risk of having heparin-induced thrombocytopenia with a number of anticoagulants. And of course, you would agree with me, it's quite difficult for patients to sustain parenteral administration with anticoagulants. Certainly, the VKAs have a narrow therapeutic window, and of course, just like the last speakers have mentioned, there is a need for frequent monitoring and dose adjustments with the oral VKs. Now, separating the apples from the bananas, we would see that for us to consider an ideal anticoagulant, we're looking for a medication that offers increased anticoagulation benefits and, of course, decreases the risk for bleeding. And this is what Xarelto will offer your patient. Xarelto is the NOAC with the most robust evidence from randomized clinical trials to a spectrum of real-world evidence. Thankfully, Dr. Ojji has mentioned this already from the Rocket AF, where we compared rivaroxaban versus warfarin in over 14,000 patients. At the end of the phase 3 trial, we observed that Xarelto demonstrated non-inferiority to warfarin, and it reduced the most critical, the most dangerous critical organ bleeding, intracranial hemorrhage, and fatal bleeding. Now, in other phase 3 trials in which other NOACs have been used, comparing, of course, say rivaroxaban versus dabigatran, we will see that the patients in the Rocket AF study were a lot sicker when we look at their CHAD score, with, of course, the risk factors were with a score of 3 to 6. Now, for patients with renal impairments, just like Dr. Ojji mentioned, 1/3 of Xarelto is eliminated via the kidneys. So this may require you to adjust the dose for patients with mild to moderate renal impairment. It's recommended that a 15 milligram once daily is administered to these patients. However, for patients with normal renal function, Xarelto can be administered for the stroke prevention in non-valvular atrial fibrillation at 20 milligram once daily. It's important, as I conclude, to mention that Xarelto has a favorable benefit-risk profile, and of course, it's easy, safe, and effective to use. It comes in 3 different doses. It comes as Xarelto 15 milligram, Xarelto 20 milligram, and Xarelto 10 milligram. Now, we also want to encourage that, of course, the patients should get only the Xarelto registered by NAFDAC and with 14 tablets in a pack. In case you have any medical concerns or pharmacovigilance concerns, here are our emails. And at this point, I would like to once again thank you for the opportunity.
Thank you very much, sir. We want to thank CardioCare and Bayer also. I'm sure you've enjoyed a lot of high stuff of atrial fibrillation. Right now, you should know about pathophysiology. You should know about epidemiology in Nigeria. You should know about the clinical features. You should know about the treatment options. You should have been dosed with a lot of studies on the approaches to use. Remember that NOACs are only used for non-valvular atrial fibrillation. Please let us remember that. So if a patient has valvular heart disease, you know, a valve in place, please remember that you should not use NOACs. Typically, we should go back to the good old trusted and long-lasting warfarin. Okay, but Xarelto is available. I can see a question: what weight is rivaroxaban not advised? I don't know that Dr. Ojji or Ayibola will be able to answer that. For what weight of patient, I presume, is rivaroxaban not advised? That's a question in the chat box about rivaroxaban. Ajibola or Dr. Ojji, perhaps, you have any answer to that question? Ajibola?
What is meant by weight? Is it talking about weight of the patient or?
Yes, patient weight. Person has clarified. Patient weight and BMI.
Okay. As not. No, I don't think that has an issue. I mean, you want to relate weight with estimated glomerular filtration rate. That is one of the most important things. And then want to consider the dose. But when it comes to the weight of the patient, I don't know if that has any real relevance in using any of the anticoagulants, even the traditional anticoagulants. Maybe Ajubala might have other things, but I don't think so.
This is correct. So just like you said, it can be used in all weight ranges.
Yeah.
And even the studies which we have, like the Rocket AF, different weight ranges were used. And this is why this study was carried out in all these different weight range. So irrespective of the BMI, of course, we could use Xarelto in, in these patients.
Okay. I don't think there's any other question. Okay, and somebody is asking whether Xarelto is covered by the National Health Insurance Scheme. Okay, so I think I can answer that, and the answer is clearly no. You know, so most NOACs are also, the comparison between NOACs and warfarin is also cost. NOACs have a significant costs implication, and so very few insurance plans do cover it. That is actually a fact. And so what happens is that the body may fall directly on the patient to pay out of pocket. That also sometimes affects compliance, adherence, and whether the patient continues to take it for a long time. So it's one of the factors that you have to consider when starting a patient on rivaroxaban or any of the NOACs, amongst other things. Okay, so for attendees, for doctors attending, if you want to get your CME, typically we do give the CMEs at the end of every 3 months, 2 to 3 months, so that we gather it together. You send your name, your full name, as it is on your MDCN, with your MDCN number, and then the topics you have attended in the last 3 months. So we'll give it at the end of September. So at the end of September, you send all of that. We typically will send you we'll check your attendance record, and we may, if we are unsure of your attendance, we may send you a short quiz to answer. Also, know that the lectures are available on YouTube, on our YouTube channel. So go on YouTube, you'll see Limi Hospitals Network. We will send you a link in your email so that you can always go there and then get it, rewatch. So there are so many topics that are there. There are topics on severe hypertension, on pulmonary thromboembolism, which we did with Bayer, on COVID and pregnancy, on chest pain management, on palpitations, approach to palpitations, so much on asthma. So a lot of management, a lot of things are there. So you just use that to in your free time. That will be very helpful to your practice. So once again, this is from CardioCare Specialty Hospital. Dr. Olalekan, Dr. Iseko, Dr. Awofisoye, and Dr. Frank, and all the rest of us are all here, and we are happy to have you. Our different specialists in different fields. That's our intensive care unit. Well, actually, our HDU, and then our intensive care unit is also there on the other side. We've had a number of CAT cases which we have done today for ischemic heart disease. We also put in cardiac devices, interrogate cardiac devices, dialysis, endocrinology, diabetes, rheumatology. Those are some of the things we do. Essentially, if it is complex internal medicine, we're hoping to start cardiac surgery really soon, in the next 3 to 6 months. And so at that time, we'll also let you know. We'll be glad to teach and share. We're essentially a teaching institution and a learning institution, CardioCare. And this is what CardioCare looks like here in Abuja for the rest of Nigeria. So even though people have problems going abroad with the COVID situation, they can always come in from any side. We've had patients from Kanu, from Sokoto, from Bayelsa, coming for different levels of evaluation and treatment. So God bless you all. Wish you a great weekend ahead. Thank you for joining us, and we hope to see you next month when we'll be talking about heart failure and how to approach it in the Nigerian setting, in whatever setting you are, and we trust that to be a very beneficial topic for you. God bless you all, and bye. Thank you, Dr. Ojji. God bless you. Thank you so much. You have always honored our invitation, directly or indirectly. We wish you the very best, sir.
Thank you, and thanks for the great work you are doing. Well done.
Thank you, sir.
And thanks to Bayer for the invitation. Thanks.
Yes.
Bye-bye. Yeah.
Bye-bye, sir.